Okay, so I'm a little bit proportionately looking larger on that. Good afternoon and welcome to UnitedTV and Bariatric Friday. After 2 weeks, we are back live with our live episodes. So we try to actually put a lot of information out there. Our main goal is to help our patients who are going through the process or they already have the surgery, and then we are trying to help them post-surgery. Now, morbid obesity is not an easy disease to fight. So this is not as simple as maybe some others, and it has a lot of connections with other illnesses. We try to use illness, but we call them comorbidities. And those comorbidities, like different type of illnesses, they come with morbid obesity or they come from morbid obesity. Today, we are going to actually discuss how those comorbidities are, the resolution of those comorbidities and how that's happening. And as usual, Dr. Irgau is going to join me. Dr. Irgau, welcome back.
Thank you, and welcome back to the show as well, Kemal. It's great to be back.
You. So it's good to be back, actually. So a little bit jet lag, but I'm okay.
Oh, you're doing great.
Thank you. So comorbidities. I know you don't like when I call them comorbidities, especially in these type of settings, because not everyone, if they don't have the medical background, they don't know what we are talking about. But in simple terms, what are we talking about? What is comorbidity?
So comorbidity essentially is a term that we use to identify illnesses that we find alongside obesity. But really a more precise term, Kemal, might be complications of obesity, right? The reason a person develops type 2 diabetes or high blood pressure or sleep apnea when they're morbidly obese is because obesity itself leads to the development of these derangements that result in diseases. So complications of obesity might be a much better term, although we are used to call them comorbidities essentially.
So now there are maybe 7, 8 of them are like very well known, right? Diabetes, high blood pressure, sleep apnea, depression, cholesterol, and there are others that we are going to go into. But one with diabetes, we know that insulin level is important, and changing the signaling with the gut and all the how much we eat. It's one of the quickest one that we see, and many people also, like one of the most common one too, right? So why do some patients see glucose improvement within days before the big weight loss? What motivates that?
So that really is a great question, but because it also tells us how surgery works, right? Some people think that surgery works because we make the stomach smaller and therefore you eat less and therefore you take less calories and therefore there is weight loss. Actually, that is only part of the story. One of the most important effects of the surgery is to change how our digestive system communicates with our brain to regulate our metabolism in a beneficial way. So with surgery, we have changes actually in the hormones that regulate our metabolism, right? It is as if we are injecting ourselves Wegovy. It's like producing your own Wegovy inside. These are hormones known as incretins, and we have them. It's just the surgery makes them much more available. So there is increased production of these hormones. There is better sensitivity of insulin. There is less distribution of sugar from the liver cells or effects that occur because of the changes of the surgery. That's why we call the surgery metabolic surgery.
Right.
As well.
And it has a lot to do, like, this is my own. So remember, in this show, you are the physician and I'm the non-physician. So you are the person who's with the license and I'm the one without the license. So everything that I say is from my own perspective personally, where, I believe once we have the peace between the gut and the brain, so even if things are not just happening, but the kind of reconciliation is there, things already start happening. And that's what I have seen in the last maybe 5 months. So if I can condition my brain that here's what we are going to do, this is what's going to happen, and then I follow certain instructions that we have with our dietitians and other providers, even without the morbid obesity, that actually reconciliation helps a lot.
Absolutely.
So
Absolutely.
now, in terms of remission of the diabetes, who is most likely to have the remission?
So clearly what we've known for a long time is that people who've had a shorter history of type 2 diabetes, less than 5 years, for instance, had a greater chances of completely getting rid of the diabetes after the surgery. And that's not universal. There are some people with longer history who also do the same, but that seems to give them an advantage, essentially. People who are not already on insulin because of their diabetes have a much higher chance of getting rid of the diabetes completely as well. People obviously whose pancreas is still working well, they have pancreatic reserve, those also have a much higher chance of getting rid of the diabetes, but also people in terms of their behavior who are adhering to the lifestyle that we're asking them to also have a much better chance of getting rid of the diabetes. But all of them, without exceptions, will have improvement in the diabetes. So the question is, who gets cured completely of the diabetes? And those people that I told you about have a much better chance of getting cured completely of the diabetes.
So what's your practical approach to diabetes med right after surgery?
So we have to watch this very carefully because of what you've just said, because there is a sudden improvement in control. If patients are already on diabetic medications, there is a chance that their blood sugar may drop too much, and that can lead to what is called hypoglycemia. So we actually tell patients to avoid taking insulin or take less insulin if they were taking insulin, and we work with their primary care team or with their endocrinologist very closely in the early days after surgery to make sure that they understand that their blood sugar is much better controlled now in the medication they were taking before. Particularly medication like glipizide might be too strong for them. So the best advice is for them to do their blood sugar check very frequently, and if they see that their blood sugar is much lower than what it used to be, don't take the medication. Either call us or call their primary care team or their endocrinologist, so there are adjustments are made to their medications very quickly.
One of the things that I see, and this is not maybe directly related to what we have today, but because of the daily case conferences, almost 2 hours every day, I go through those with our nurses and with different people in the team. Like someone who has thyroid problem with the TSH, they are on the higher dose of the medication. And like 2 years, they didn't make any changes, but their TSH actually is now
still abnormal or normal. Okay.
So I'm thinking, why would they not try to reduce the dose of those medications, even if, again, outside of this bariatric and the morbid obesity spectrum? So I'm like, this patient's TSH is 1.7 in the last 6 months check. And then they're on 150 milligram of the TSH medication,
Synthroid, yeah. Synthroid, yeah.
So I'm like, why would you try to reduce that? At least try, because there are different...
That's a fair point. So one argument would be precisely because it's keeping the TSH normal, right? So if the TSH is normal, means that medication is actually working. But generally, of course, patients who are on thyroid medication should have the levels of their TSH, but also the free thyroxine levels in their blood
T4.
checked. Yeah, that's right, T3, T4, checked on a regular basis to make sure that the medication that they have been given is appropriate for them, of course. Now, the interval of checking this is going to be variable from patients to patients. Patients who've been stable for a long period of time perhaps will need a check-in there, less frequently than patients who are less stable with their levels.
Now, our next one is hypertension. So again, these are the most common ones. And for me, between the two case conferences, 1 hour with the ACO, 1 hour with our morbid obesity program, even for those who don't have morbid obesity, hypertension is there. But when it's with morbid obesity, complications are there. So, and as soon as I see the BMI on someone who's having issues with the BP, their blood pressure, I'm like, why not try to lose weight? So instead of like being on 3, 4, 5 different medications. So when do you start seeing blood pressure improvements, and what do you tell your patients?
So I will get to that in 1 second. You know what made me think about what you said is you're having daily conferences focused on chronic disease on a daily basis.
Right.
You are the head of United Medical ACO. It means the ACO is so focused on reduction of chronic disease.
Correct.
It's no wonder that United Medical has been ranked as one of the top 50 ACOs in the country.
Thank you.
Right?
Thank you. Yep.
It's precisely because of that focus, obviously.
Thank you.
Going back to that question of the blood pressure, people will see resolution within weeks or months. Again, blood pressure actually can start improving very quickly because of rapid weight loss, but also less fluid intake very early after surgery. Because of that, patients need to watch for the blood pressure medications being too much for them. So we tell them to actually contact their primary care doctor or their cardiologist, whoever prescribes their medications, to make adjustments, because they may experience dizziness early on because the blood pressure medication may be too strong for them that early after surgery.
Right. What about lipid disease, hyperlipidemia? Do you consider lipid disease resolved after surgery as well?
Absolutely. So the resolution may not be complete. Some people may require less medication, and people may not need medication anymore. However, the question of whether they still should be on cholesterol medication or not is also dependent on their what we call atherosclerotic disease risk, right? So if they have a lot of atherosclerotic disease and they are high risk for atherosclerotic cardiovascular disease, then they may have to stay on cholesterol medication even if the cholesterol has been reduced significantly with the surgery.
Right.
Yeah.
So sleep apnea is another one that's many people, they don't get their sleep screening. We call them stop bank score or sleep apnea score. When you actually do a home sleep study on people, not you as the provider, but it's when it happens, many people don't know that they have it, or many people don't understand what it is. And with the morbid obesity, this of course becomes a very important issue, especially right after the surgery. Recovery is very important. So what's the experience on the CPAP that they utilize to control? What's the experience that you see with your patients? What do you tell them with their CPAP utilization after surgery?
Yeah, sleep apnea is actually one of the early complications of obesity that improves with rapid weight loss. And very often patients will feel great and they will sleep much better than they did before. And there would be a temptation for them to get rid of their CPAP machine. But I always tell them, don't do that. Wait to be tested again formally, and then your doctor will decide whether you don't need the CPAP machine any longer. even a milder level of sleep apnea may require a CPAP machine to make sure that the risks associated with sleep apnea are reduced with the CPAP machine, right? And also there is evidence that good sleep aided by the CPAP machine actually leads to better weight loss as well. So I tell patients, don't be in a rush to get rid of your CPAP machine if you have not been properly tested again.
Right, and we want them to actually check with their healthcare providers,
Absolutely.
with
Absolutely.
their primary care and other specialties as well. But knowing that sleep apnea related to morbid obesity is one of the really important issue, I think they see, especially people who probably sleeps with them, they can actually see the issue a little bit more. But one underrated problem that I see is how people, they kind of complain about being tired because they didn't have a good sleep.
Exactly.
So well, they are thinking about all these other things, but then they're not looking at, hey, you didn't sleep well, and the reason you didn't sleep well because you have sleep apnea. The reason you have sleep apnea because you have morbid obesity,
Yes.
right? So they're kind of all connected to each other. So
Absolutely.
it's kind of interesting how people ignore these things easily. Now, fatty liver is one of the other problems that we know, also very common.
Yes.
What is fatty liver?
So fatty liver disease essentially is one of the probably one of the more dangerous complications of obesity, because it leads to liver dysfunction. Accumulation of fat in the liver leads to changes that they can become the same changes that you get with somebody who has alcoholic liver disease, leading to something called cirrhosis. And from that, you can actually go on to develop liver cancer as well. So people are understanding the significance of this more and more now. It used to be called non-alcoholic fatty liver disease, or non-alcoholic steatohepatitis. And the reason for that, Kemal, is that doctors for many years knew that people who drank excessive alcohol ended up having cirrhosis of the liver, which very often killed them, right? And what they found out is when they looked at the liver of people who drank excessive alcohol and at the liver of people who had obesity or diabetes, the changes they saw on the microscope were identical. But one was caused by alcohol, and they knew about that. The other one, the person never drank, right? So they called it non-alcoholic liver disease. But the actual changes on the liver are very similar, and the consequences are similar as well, leading to cirrhosis and leading very often from cirrhosis to cancer as well. In fact, it's no surprise, Kemal, that in the United States now, the liver disease caused by obesity is a very common reason for people to seek liver transplant. Think about that, right? You never had any alcohol problem. You have morbid obesity, and now you're developing liver disease that may lead to cirrhosis or to death or to cancer of the liver and requiring liver transplant. And if the changes in the liver are in their early stages, this can be reversed completely with weight loss surgery and reduction of obesity.
So one of the questions that I had for today, maybe I'm gonna not ask you that. It's related to GLP-1s.
Sure.
Because there are some new developments, cost-related. And I'm going to verify a couple things before we actually talk about it.
Sure.
So there are some pushback from the employers. The cost of this is being outside of reasonable limits, and the reason for that is also not being actually being effective. So I'm going to reserve that question for GLP discussion, most likely either next week or the following week.
Sure.
But some interesting developments are happening with the GLP world. So we'll see. I guess everyone will find out more between now and the next meeting. Now, we know, I kind of know the answer, of course, but in terms of these comorbidities coming back, what are the top reasons they come back?
So there are a number of factors, of course. The most obvious one is weight regain, right? If you really are not focused and you're not staying on course with your lifestyle changes and you allow your weight to come back, obviously the weight was the cause for the diseases before, and weight coming back will get the diseases to come back as well. So that's very important. Loss of follow-up, right? Behaviors like grazing, for instance, eating continuously. You cannot eat a lot because you have a lot of stomach, your small stomach, but if you're eating continuously, the classic example is somebody who works in an office, 8 hours of a day, and they have a big jar of M&M or other, calorie-dense foods that they go in very easily, and they are munching on that continuously. That's grazing. That will lead to increased calorie intake and therefore also return of the weight. Inadequate protein intake, obviously low activity level, and then struggles with mental health. Although all those factors can lead, but the bottom line is really you are getting back to the same situation in terms of your eating habits, less activity, which will lead to weight regain as well.
I kind of because I'm not the licensed person, so I have more freedom. So I think we are not being honest with ourselves, patients or people. Not you, not the program, but I'm talking about us, like Ethan, me, other people, my older sister. We won't name her, but
she may be listening.
she is listening. We always try to figure out some other problems than the most kind of obvious one. So our body is already talking to us. It communicates. Or you have to be kind of in charge of what's happening. So, for example, if you have a long flight, and if you are, and when I say long flight, I'm talking about 10 hours just the flight itself, but then 3-hour car ride, and then another 1-hour connection. Door to door is 21 hours. So just because it's a medical channel and I can be a little bit gross, but I need to see what's going to happen with my bathroom needs. The number one is not a problem. Number two is a problem.
Right.
I need to prep.
Right.
What prep is that I need to change what I'm eating a little bit so that I know what's coming. So if I just, go ahead with like ice cream and the puddings, and that's like less protein, more carb, well, I'm going to have an issue on the plane. Now, take this in any other scenarios. If you are going for some work event or other things that you need to do, you have to prep. Prep meaning you have to prep your mind. Okay, what's coming? So, or what's happening to me when I eat this? So, and since we do these things, I try to pay a little bit more attention, and I have a problem doing business in public places, so I have to worry about it, and it works. So the day of, the night before, I was heavier on protein. So, and it helps because then I know that kind of it's preventive, right? So I know what's coming.
Right.
So, and if I know what's coming and if I can change that with my behavior, then I need to make that adjustment. I don't want to hear this people who complain about their blood pressure and they don't do anything to change that, right? So I have a couple of friends, and I'm sure they're listening now and they know that I'm talking about them. Oh, they were in the hospital for blood pressure. Well, I'm sorry, but you are morbidly obese. What do you expect? Why do you think you wouldn't have blood pressure issue if you are like, these are like elderlies too, so I know it's difficult for them to lose weight, but if you are 40 kilograms, almost 80 pounds more than where you should be, well, you are going to have those issues. So, or if you eat and your stomach is not happy, well, look what you are eating. That's my sister. So like we were away for a couple of days when I was in Ankara, and she complains, and then she takes medication. She like on her own. So like it's in our family. So, and I'm like, you mix a lot. That's what I told her. And you know how I keep my food simple, and because we are siblings, so I know what bothers me, and most likely that's what's bothering her. So she doesn't eat a lot, but she mixes way too much. And I said, okay, so tonight we are not going to mix that many. So from her plate, I took 3 different things and left her with 2. Enough for her to be full. It's not about how much she eats, but what she mixes. So the idea is, hey, stop doing this. So if you are having an issue, right? So I think that's why I'm saying that let's be a little bit more honest with ourselves, but also communicate with your body, and prep your body. Like right now we have someone in this room outside of me, Ethan, and yourself. He's sleeping, I guess. He's uneventful, right? Joshua is with us, and I keep him. He's on my his leash is on my ankle. So if I leave him free, what's going to happen? We know what's going to happen. So we know that we can predict what's going to happen. So that's why I'm saying that, hey, talk to your maybe stomach a little bit more. Think about what you went through before. And, when, like this time, 2 weeks, I was more careful with gluten products. It bothers me. I don't care what people say. With age and with how we maybe eat different things and certain habits, the thing that was not a problem 25 years ago, it's a problem today. And I deal with that. And I don't care about what you think. Not you. I do think about. I value your opinion, but other people, if they don't understand this, I don't need to explain this to them.
No,
so, one of the maybe real person perspective of issues with comorbidities and others, listen to your body, because your body is telling you a lot.
I like. You said, talk to your stomach. That's a great thing. It doesn't. It sounds obvious, but we don't think about that. That our body actually gives us signals, and we should be listening to them, or we should be learning by the signals we get, and that goes along with the issue of accountability and personal responsibility as well. As part of what is needed for us to succeed, and all the interventions that we are advocating, whether it's medication or surgery, is not going to go all the way unless that part of accountability and responsibility is also part of it. So it's really a contract. I, as a doctor, will do XYZ, and you, as a patient, have to do these other parts. And these 2 things need to be there for it to work successfully. It's a teamwork, essentially.
So now, speaking of mixing and not mixing, rate with Dr. Irgau.
All right.
So
what do we have today? Let me look at what we have.
We try to have different things, so to keep it a little bit more real. So our team in Turkey said, hey, what about the Turkish cuisine? So I'm like, sure, why not? I didn't pick any of these, and I don't probably eat many of these, so I'm going to try to follow what we have. So as soon as Ethan is
and we
ready,
have pictures of them, right? They're coming up.
So this is Turkish food, but it's also Greek food, Middle Eastern food, Lebanese, Syrian,
Mediterranean.
So Mediterranean. So it can be anything, but because the channel owner is Turkish, we are gonna honor Turkey.
Okay, wonderful.
So we start with, so this is where actually I'm from, Dr. Gades. Kayseri is my origin.
Okay.
And mantı is these tiny dumplings, and it's with yogurt and garlic, and they put a lot of butter sauce on top. So we'll go with Kayseri mantı. So 1 out of 10.
5 out of 10.
5. No, I mean like 1 to 10.
Yeah.
So
5 out of 10 would be the score, and this is because, yes, of course, it does contain protein from the meat, and the yogurt, but it's very carb heavy, right? For our post-bariatric patients, this would be portion controlled only. It's not something that I would advocate, but they have to be very, very careful with the portions. The fact that it has protein obviously is an advantage, but they cannot take it excessively because of the heavy carb presence.
So in the origin city, Kayseri, they the best ones are how many you can fit into one tablespoon.
Okay.
So they're very like small. So I think my grandma used to fit 57 or 54 if I'm not
small
mistaken.
is good. Yeah, that's excellent. Yeah.
It's a lot of work, so a lot of manual labor, but it's delicious. I try not to eat, but because of the gluten issue. So,
Yeah.
but it's really it's a good Turkish cuisine. So, well, one is famous lahmacun. It's a thin flatbread with spice meat topping. This usually makes me sick. And go ahead.
It's like a Turkish pizza, essentially.
It's like a Turkish pizza. Yeah.
6 out of 10. The fact that it's thin crust is a good thing. Obviously, there is lean minced meat in it. Much better, obviously, than the thick pizza that we're used to. For our bariatric patients, I would say small portion would be acceptable.
We almost had that yesterday in New York, but they didn't have it, so they were out. So I was lucky. So this is the problem. Like, I know it's gonna make me sick, but I still want to eat it.
Okay.
So, like, anything that we say doesn't mean that we don't do it, but we are just advising not to do it, right?
Of course.
So the next one, number 3, is kumpir. This
Okay.
is stuffed baked potato with
Ooh.
topping.
Okay. I think that's going to be 3 out of 10. We have a large carb load, obviously butter and cheese, processed toppings. It's very calorie dense. It's a definitely poor choice for our bariatric patients, so I would not advise that for our bariatric patients.
And the next one, I believe you tried this at my house, lentil soup, mercimek çorbası in Turkish.
It's a good one. 9 out of 10.
Oh, right.
Yeah, absolutely.
Good.
Fiber-rich, plant protein, lots of micronutrients as well. This is an excellent choice for our bariatric patients as well.
So next one is a dessert, and it's kind of like one of those like a balm style künefe. This is a cheese pastry soaked in syrup, and usually I think they put something on top, but you eat it like warm, kind of not too hot, but kind of warm. Last time I had it 30 years ago. Go ahead.
1 out of 10. This is a big no-no. It's like extreme sugar and fat load as well. Definitely not a good one for our bariatric patients. High risk for dumping syndrome as well.
So, and it's a lot of sugar.
Yeah.
So our next one is kind of like a general term they use, kebab. This can be shish, Adana, döner, plate style.
I would say 8 out of 10. This is good, high quality protein. Of course, the fat content will vary, from the cut itself, as you were mentioning. For our bariatric patients, it's very good if it's eaten, obviously, without the bread or the rice.
I was just going to say it comes with pire, so try not to eat the pire.
Yep.
So, next one is your favorite, menemen. Menemen is a egg with tomatoes, peppers, often with cheese.
Of course, it's my favorite, and I'm going to give it 9 out of 10.
Oh, right. So,
eggs, vegetables, olive oil, all nutrient dense, essentially, very well balanced, excellent for our bariatric patients as well.
All right, and the next one, I do like this one. It's mücver, it's zucchini fritters, often pan fried.
I'm going to give it a 6. And the reason is because the frying adds fats, obviously, and the flour adds carbs as well. It does contain vegetables, but it's being fried and it's being, prepared in flour as well, and that obviously increases the carbs and the calories as well.
All right, so the next one is a drink. It's Turkish coffee.
8 out of 10.
10 out of 10.
0 calories and obviously rich in antioxidants. Generally fine for our bariatric patients, but obviously not so good early after surgery because it can irritate the new stomach. And we tell our patients to stay off
They're
from
very
caffeine.
small cups.
Yes, but lots of caffeine in there,
Lots
of
of
course,
caffeine.
because it's concentrated. Yeah.
All right. Another drink is most Americans kind of don't like this when it's plain and healthy, but
Mhm.
I strongly recommend Ayran yogurt drink.
I would go with your recommendation 8 out of 10
There we go.
because of the probiotics, the protein, and low sugar as well, of course.
So this was our Turkish cuisine rated with Dr. Irgau. So I think we did okay.
Yeah.
Turkish food overall, it can be based on the region in Turkey. It varies. So different type of food. Mediterranean side is much healthier. As you go to the middle, things with the mantı, the dumplings, and as you go southeast, kebabs, they eat them with a lot of
Sounds like if you
Pide.
stay away from the desserts and the sweets, you're good with most Turkish foods, right?
Overall, it's healthier. So
Yeah.
like this time, I didn't put a lot of restriction other than the portion restriction. I did okay.
And they use a lot of fresh ingredients, right?
They-
Yeah.
all fresh.
Fresh,
So
yeah. Wonderful.
if you do it in the right place, it's good. But again, portion control is important.
Absolutely.
And also not mixing a lot of things and knowing what to mix and what your stomach likes or not. So try carefully, but you'll be actually pleased. So we are at the end of our Bariatric Friday. Now, one of the changes that we made, and I believe first episode was last Tuesday, our webinar format that we changed. Now
Yep.
we have that on YouTube.
Yep.
And I believe the first one that aired with Dr. Mike Peters,
Yep.
we unlist that in between weeks from one to the next.
Yep.
So every week we are going to have a different provider presenting those on Tuesday.
Excellent.
And that's very specific technical
Mhm.
for patients
Mhm.
who are at the beginning of their process.
Absolutely.
So we want patients to take advantage of those sessions, and they will be available from every provider. So we have 5 more to do. Did we do the second one yet?
We did. Yeah,
We did.
Dr. Singh.
Dr. Singh did the second
wonderful.
one, so that's
Wonderful.
going to air this coming Tuesday.
Excellent.
Good. Hopefully more people will be able to watch those on their own,
Absolutely.
so it doesn't have to be, but we are going to air them on Tuesday at 6 p.m. except the first Tuesday of the month, because that's our support group.
Support group, yeah. Yep.
All right. Well, Dr. God, thank you for joining me today. And
you.
we hit 250,000
All
subscribers
right.
last week.
Congratulations.
And
Yeah.
I finally received my YouTube. Where do I show this? So
Plug. Wow,
here it is,
wonderful.
plug. So this
Yeah.
is normally it's 400,000. We should have received this physically. We should have received this maybe 8-9 months ago. Some technical issues, but now we have it. So working on 1 million next. That's
There you
so
are.
we have about 750,000 to go.
We'll get there.
We'll get there.
Yeah.
Well, thank you for supporting us, watching us. We are extremely happy that this is helping people who are actually watching, and we'll be back with more things. And until then, stay united. Thank you. Bye-bye.